goed is, ben je er nu in. Dank je.
Oh, ja, tuurlijk.
Ja.
Hallo. Hallo.
Hallo.
Oké, succes.
Yo. Hey.
Hi there.
Hey guys, how are you doing?
Hey, Ingmar.
Good.
Hey, good to see you guys.
Good to see you too.
So,
Great. So yeah, Eric, you'll be the moderator, if I'm correct.
I will be the moderator of your session. You got that right.
Okay,
Let me
great.
see.
We just had dinner, so we're just starting up again. Excuse me for that.
So Alan has not joined us yet.
Yeah, so we're just waiting for Alan.
Good.
I can
We
message
did meet
him.
before, Ingmar.
Yeah, we were in the training
We did meet
together.
before, didn't we?
Yes, at the
Right.
match.
In Stony Point.
Ellen is er, ja.
Yes.
Yeah, there's Alan. Hey,
Hey,
Alan.
Alan.
Good to see you. Hi.
Hello.
Okay. Hey guys.
Hey.
Just a few quick
All right.
announcements. For you, Eric, we want all the conversation to go through Zoom, the Q&A. So just ask everyone to post their questions within Zoom and not via Huva, because that doesn't seem to work as well. Another thing is, we'd also ask if you guys want to, we could do an after talk that would allow you, we'd make a separate community meetup within Huva, and you guys could join and talk about the topic further with people when time runs out. And then, I don't know, are you guys interested in that?
Alan, Ingmar?
I'm open to it.
Yeah, I'm not sure.
Okay. Well, then I'll just say, well, Ingmar will be available, but then I'll just say that they might be
You can
available.
send me the information, and
They might look for it.
Yeah, exactly. It's just after this talk for 15 minutes. It's not.
Just for 15 minutes? I can definitely do that.
Okay, great.
Yeah. Okay.
And then, do you guys all are you timing your talks approximately?
Well, I have a pre-recorded one. I was hoping that we'd be able to use that. Is that still possible?
Okay, I'd have to grab that.
Well, Ingmar's second, so you can look as we go live.
Great. And then Alan, you could just present and then just keep an eye on the time. I'll ring a bell.
2 hours, right? 2 hours to present.
Was that 2 hours to present? Yay! Yeah, we'll go for that. We definitely go into that channel.
So
yeah, 12 minutes?
Yeah, I think it is 12 minutes, if not correct. But then I'll give a bing if the last minute in case you lose track.
Oh, good.
And then Eric will just host and moderate and also ask all the questions.
Right.
Okay.
No,
yeah?
you got a little bit more than 12 minutes, Alan. Right, because we got until 2025. So the total is it's 30. We got 40 minutes in total.
Yeah, we have 40 minutes, but I think we're doing like 12, 30 minutes talk and then a Q&A at the end.
Sure.
Yeah. Okay, well, if you guys are ready, then I'll broadcast it. You guys ready?
One question for Alan. Did we meet before, Alan? Have we met before? I was just thinking.
I'm not sure. I feel like we have met before, but I'm not sure.
We're not going to disclose it.
Lovely to meet you.
Good to meet you. You're in Baltimore, right? And Ingmar is in.
I was in Baltimore. I'm now in Ohio.
Okay.
Yeah, I live in Columbus.
I saw your bio and the interesting crossroads in 2017.
Yes.
All right. If you want to say something about that or so, that would be lovely.
Okay. Saying about 2017?
Yeah, well, it's interesting, your bio where you were in that crossroad and you moved to Johns Hopkins.
Oh, yes.
Yeah.
Yes. Okay.
Yeah. You go first and then I'll introduce you and then you'll take over, and then Ingmar, you're going to be after the Q&A of Alan. And we'll make it a little bit playful if you don't mind. It's an important topic, but people are glued behind their screens and they've just had dinner and stuff. And so We'll try to not laugh about it, but make it interactive and lively if we can, right? All right.
Yes. Okay, great. Then I'll put you guys on in 3.
And I just want to make sure you've given me permission to share my screen, correct? For my
Yes,
slides?
yes, it should be able to share it.
Great.
Okay, great. In 3, 2, 1.
Okay, hello, welcome back to the in the Netherlands. It's the evening session that is called Beyond Symptom Reduction. We have some stiff competition in an online conference like now, because on the other channel there is integration, but this one is Beyond Symptom Introduction. My name is Eric Vermetten. I'm a psychiatrist in the Netherlands. And we have with us Alan Coy-Davis and Ingmar Gorman, who are going to present to us 2 fascinating talks. I've read your abstracts, and the order in which we're going to do it, Alan, you're going to go first, and then a little bit of Q&A, and Ingmar, you're going to be next, and then Q&A, and then we'll probably have an open discussion at the end. So Alan, I read your bio with great interest, and you just moved from Ohio to Johns Hopkins. Now, I think you moved back or so, just a couple of years ago. Interesting bio. Could you say something about 2017? What happened in your life or so when you had this interesting crossroad that everybody could read about?
Sure. Well, so around that time, I was finishing up graduate training and I was in a postdoc fellowship at the University of Michigan. Unfortunately, there wasn't any psychedelic research going on there, and I wasn't really sure how I was going to find a way to this path in my professional world. And so I happened to start the CPTR program at CIIS, which here in the States is a psychedelic therapy training program in California. And also got a call that there was a position available at Johns Hopkins, and so I applied for it. And in any event, it was a big transition time for me, and yeah, very, very exciting. But when I went to my mentors at the time and said that I wanted to pursue it, they told me that it might be a big mistake. They thought it was too fringe and too radical, and they weren't sure it was going to pan out. And now I'm kind of looking back and thinking, now they want to say, oh, well, we always knew it was going to be great for everybody. So it's interesting what a couple of years can do to change people's minds.
Hey, Alan, thanks for sharing that. The title of your talk, as it is on the WUVA, it's Psychedelic Occasion Decreases in Trauma Symptoms Among People of Color Who Have History of Racial Trauma. Is that correct?
That's correct, yes.
The floor is yours, Alan.
Thank you so much. I'm going to share my screen. Please let me know if anyone's having difficulty seeing my slides. They should be appearing now.
Yep.
Wonderful.
Coming in.
So, so I'm going to present today on what I think is a really exciting project where we have started to look at really underrepresented populations who have been experiencing psychedelics, and in particular people of color who we've had a very challenging time recruiting and also really kind of making space for, I think, in psychedelic medicine. And so this is our first attempt, at least, to one, to better understand what's going on among people of color who are using psychedelics, but in particular to better understand possible clinical benefits. So that's what I'm going to be talking about today. And of course, as every study and every person involved in a team knows, nothing happens in isolation. So this is part of a much larger team of folks who have come together to work on this, including my colleague and partner on this study, Dr. Monica Williams at the University of Ottawa, Nathan Cepeda, Yitong Zhen, who is my graduate assistant at Ohio State, among other people. And funding for this came from the University of Ottawa, as well as funding for my general work comes from private donors, as well as the Stephen and Alexandra Cohen Foundation. So I'm going to talk a little bit today about the background of this topic and why we are interested in it, which should be pretty self-evident, but we'll mention it nonetheless. And then I'll talk about some of the effects that we were curious about investigating among people of color, as well as our primary findings and future directions. So I know that I don't need to spend too much time on this in terms of helping this audience understand, but I want to draw two pieces of information from this. One, that we're interested in looking at the mystical experience, and that's been, one of the most often reported experiences, at least in the clinical trials, talking about what might explain transformative psychotherapeutic experiences. But in addition to mystical experience, we've also become very interested in the insight experience, or what might be colloquially known as the download, or the new information or realizations that come for some people during a psychedelic experience. And in particular, we're interested in what might happen when those happen at the same time. And what we call that is quantum change, when one has a deeply mystical or potentially spiritual experience at the same time as they receive this new information. And that might lead to rapid and enduring transformations in people's lives. And this was not a term coined by me, but by William Miller many years ago, before I even knew about psychedelic research. So the topic is not new to it's not new to the world, but it's new to kind of applying it to understanding psychedelic experiences. And so what set the foundation for this, we've conducted a number of survey studies over the last 10 years, trying to understand what people's experiences are of psychedelics. And in this study, this first study that we looked at, was among people with alcohol use problems. And we were interested in seeing whether or not people with alcohol problems in their natural environment experience changes in their alcohol use as a result of psychedelics. But what you might notice here is that overwhelmingly the sample was white, and most of them were male. And so although this is an interesting kind of step in understanding people's experiences, the sample is underrepresentative of people of color. But nonetheless, when we look at this quantum change model in this primarily white sample, we see that insight and mystical experiences are related to decreases in alcohol use. And this is outside of a clinical trial, but it points to people's experience with psychedelics broadly. And then we followed that up with a survey of people with depression and anxiety. And again, this was all setting the foundation for our people of color survey. In this study, a large sample of folks, we have a similar demographic, primarily white, primarily male. And again, that was at the time kind of what our surveys were attracting. Nonetheless, we see a similar pattern here of the importance of the acute insight effect as well as the acute mystical effects of psychedelics in decreasing depression and anxiety. So we're starting to see a pattern here with these prior studies, but again, they lack representation. So why is it important to start to examine this topic among people of color? Well, ethnic discrimination and racial bias is very prevalent, certainly here in North America, but also around the globe. What we see is that it can create a substantial burden for those folks who experience it. And unfortunately, currently approved treatments for things like trauma are limited in effectiveness and adherence. And they have not traditionally been tailored for people of color, even though they have become gold standard treatments in other populations. So it's possible that psychedelic therapy could be helpful for people of color, but we right now don't have any clinical trials on the topic. So we were specifically interested in looking at whether or not people in their natural environment are experiencing changes in these symptoms as a result of psychedelics. So we were able to do a large survey in the US and Canada. 517 participants of color participated, and we looked at whether or not this group was, they had to be diverse in order to get into the study, but we did want to look to see if we could make a more balanced female and male grouping, which we were able to do. So about half of our sample were women, and about 35 or a third were Black or African heritage, about a third were from an Asian descent, and smaller proportions were reported as Native American or Indigenous Canadian, or Native Hawaiian or Pacific Islander. For these people, primarily they reported using either LSD, psilocybin, or MDMA, although some of them did report other psychedelics like 5-MeO-DMT or ayahuasca. And what you see here are the changes in mental health symptoms from before to after a psychedelic experience. So across all of the domains, depression, anxiety, stress, and trauma, we see significant decreases in symptoms reported from before to after that experience, whether it was with LSD, psilocybin, MDMA, or another psychedelic. And one of the strongest effects that we saw was for the racial trauma symptoms. What you see here is a combination of all of these variables into an overall model that might help us better understand and encapsulate the experience of what this group of people of color had reported. On the left side of the screen, you see all of the different acute psychedelic effects, the mystical experience, the insight experience, as well as challenging experiences. And all three of those types of effects were predicting this domain of acute psychedelic experiences. And that was significantly related to the decreases in racial trauma symptoms, the decreases in depression, stress, and anxiety. And importantly, the challenging experience, it was for this sample, the less challenging experiences that they had was significantly related to more change, along with greater intensity of mystical and insight experiences. We also saw positive and desirable changes in this sample. So it wasn't just that their trauma symptoms had improved or their mental health had improved, but this sample reported a lot of positive changes in their attitudes about death, their spirituality, their behavior, their mood, their attitudes about self and life, their relationships, the meaning that they found in their life, the purpose of their life, and most notably, almost 80% of the sample reported a positive and desirable change in their well-being and life satisfaction. Now, this was just a one-time survey, and so we don't know causally whether psychedelics were solely responsible for these changes, or their change in their trauma symptoms were solely responsible for this. And in fact, what we find from a lot of our clinical trial work is that sometimes the psychedelic experience is more vague than that, and it's not so clearly related in someone's understanding of the positive effects that they've had, but instead they notice that there are these global positive improvements in their life. And that's certainly what we saw among these people of color. So where does that leave us? Well, one thing that we continue to see, not only in our surveys composed of primarily white and male survey participants, but now in this new survey of people of color, that we see similar findings in terms of the mystical, the importance of the mystical and psychological insight effects that both together appear to be important in producing overall behavioral and psychological changes. And these findings across studies are now taken into clinical trial world, and we're starting to see similar patterns there with the importance of insight and measuring and understanding insight. These findings could explain a transdiagnostic mechanism of change, meaning that it might be that this quantum change produces positive benefits across lots of different people with a lot of different problems they might be experiencing. And so we're going to continue investigating this. My hope is that we're able to get funding and start a clinical trial specifically for people of color who've experienced racial trauma. I know Dr. Monica Williams is incredibly interested in trying to find funding for something like that in Canada, and myself in the States. And we're also currently working with studies in underrepresented populations, including Spanish-speaking individuals, and hopefully soon a new study for people who identify as LGBT. So with that, I just said all of that. So I'm just going to put a quick plug in for Source Research Foundation. If you're a student or someone looking for funding to do research in psychedelics, please seek us out and find us on the web. We provide small grants to students, and we, in 2021, will launch 2 people of color grants, one for a person of color who's a student, one for a person of color in the community to bridge science and communities. So please check us out if you can. Thank you.
Eric, I think your mic's muted.
Yeah, thank you for saying that, because, okay. Thank you, Ellen, for that fascinating talk. I do see two questions now, but I had one when I was listening to you, Alan. If you allow me to, because of course the obvious question is are there also any negative effects or so that people reported in the surveys that you did?
Sure,
You
it's
didn't report
important. Yeah, it's important to keep in mind that not everybody reports positive effects. That overall, we see these global changes across the group of people in the study. However, there were people that reported no benefit or actually a worsening of symptoms. But in general, most people reported positive effects of their psychedelic experience.
Yeah, because the setting in which these psychedelic experiences were experienced or so might have differed. Right, we've been talking about psychedelic assisted psychotherapies, but these were independent of the psychotherapeutic support. Am I getting that right? These were the experiences.
That's correct. Well, I guess more accurately, what I would say is that they might have had support for their experience, but they weren't specifically in a clinical trial or in a psychotherapeutic environment. But they might have had other types of integration support, like friends, trusted people to talk to about their experiences, or maybe been in therapy at the time. But these were not psychedelic therapy sessions.
And any favor that people reported in the types of psychedelic use? Was it MDMA over psilocybin, or did you not specifically find
So we
any?
looked at that question. We looked and compared whether there were differences in outcome between psilocybin, LSD, and MDMA, and we did not find any. There were no significant differences between what was reported between the drug groups.
Okay, let's do one question and then go to Ingmar. It says from Destiny Carbello, oh, I'm so grateful for this research. Do you know if there are any psychedelic neuroscience labs looking at racial trauma?
Not that I know of. It would be great if there were, but I don't know of any.
Rafael Lancelotta asks whether there were any social support measures taken.
So we did not measure social support in this study. And so we don't know whether they had specific types of social support in their life, or maybe it's possible that all of them had some of that, and that's possibly why they experienced benefit, but we did not measure that in this study.
Okay, well, thanks for now. We may see some other questions coming in with a little bit of a delay or so, and thanks for now. You're going to stay with us, Alan?
Yes.
Right? Okay, thanks again. And then we'll move to Ingmar. It's 20:03 on my computer, so we still have time enough. Ingmar, welcome. And
there.
a very fascinating bio that we all could share on our WUVA from you, studying at Bellevue in the past. And maybe you could introduce yourself a little bit to the audience and then chime off.
Yeah, sure, I'd love to. So I'm a psychologist, currently in Florida, but was living last 10 years in New York City. I have been interested in the field of psychedelic research since I was an undergrad in about 2005, 2006. And just over time, developed my relationship with MAPS and have been privileged to be asked and serve as a co-clinical investigator of the MAPS phase 2 and 3 research of MDMA-assisted psychotherapy for PTSD. Mm-hmm. I have a little bit of an introduction, actually, now that I think of it, also in my presentation. So to not to do it twice. Now I'm just recalling, but I really appreciate the invitation. You'll hear from me in the talk. And I just want to say it's an honor to be here today, and also to be here with both you, Eric, and Alan.
Thank you. Nice that you could make, and thanks for being here. You want to start, or you can start? Right, well, there you go.
I thought I saw, I think they have the pre-recorded version.
Right.
Let's see.
Let's see if they can get it started.
It was up just a moment ago.
Uh-huh. I'll just give it a sec. We'll hear from the jury.
Een jury bij een wedstrijd is...
Oops. There, I think that I see something moving.
Okay, is it playing or not yet?
No.
No,
okay.
We don't see it on our screen. It was there just a few moments
Okay,
ago.
this is it.
Okay, thanks.
Okay.
There we go. Okay.
Do you have it playing sound? You may have to do the play sound through the computer.
Excuse me?
I don't think the sound is coming through.
Okay.
Play sound through the computer.
Yeah, under share screen, there's a more option, and there you can click play sound through computer, and then it will play the sound as well.
Mm-hmm.
Having to do a lot of Zoom presentations
Oh,
over
okay.
the last for this panel, and I think it speaks to the importance of discussing the outcomes of research, looking beyond symptom reduction, and also looking at how people are flourishing in their lives. A little bit about me. I'm a psychologist. I'm the co-founder, along with Dr. Elizabeth Nielsen, of an education company called Fluence, as well as a former NIH postdoctoral fellow at NYU. I'm speaking to you today as a therapist and principal investigator of phase 2 and phase 3 trials of MDMA-assisted psychotherapy for PTSD. My co-principal investigator in New York City is Casey Paleos. Of course, this research would not be possible without the support of the Multidisciplinary Association for Psychedelic Studies, MAPS. Today, we'll be talking a little bit about MDMA. Of course, we can't go into great detail the amount of time we have, but it's known to have both pharmacological and psychological effects. The pharmacological effects include changes in serotonin, dopamine, cortisol, norepinephrine, oxytocin, prolactin, and all of these effects also, pharmacological effects have psychological effects. The ones that I'm going to be emphasizing here are improvements in self-reported well-being, enhancement in interpersonal closeness, empathy for self as well as others, enhanced introspection. And these are studies and findings that come from studies with healthy volunteers. And it kind of speaks to, well, one, how this might be useful in psychotherapy, but two, could these particular effects be useful in people's lives being enhanced and not just having their symptoms reduced? Speaking briefly about MDMA-assisted psychotherapy, this could be worth hours of lectures to discuss what this is, but in brief, it's psychotherapy enhanced with MDMA, beginning with 3 non-drug preparation sessions that are 90 minutes long. And then there are 8-hour experimental or dosing sessions where a person receives the MDMA. And after each of these sessions, there are 3 non-drug 90-minute integration sessions. And the therapy is generally inner-directed. And I think of this as helping a participant find their way to their own healing. Briefly about PTSD. This is a reaction to experiencing or witnessing a traumatic event. The DSM understands this as symptoms of PTSD consisting of a re-experiencing of aspects of the trauma, avoiding trauma-related stimuli, experiencing negative thoughts or feelings, and experiencing hyperarousal or reactivity in relation to the trauma. Now, generally, many people experience trauma in their lives, but only a small minority of individuals experience PTSD as a consequence. In terms of numbers, the prevalence, lifetime prevalence of PTSD in the USA is estimated to be around 6.8%. And at any given year, 7.7 million US adults suffer from PTSD. But how do we measure PTSD? Well, we use something called the Clinicians Administered PTSD Scale, or the CAPS. In this study, we'll be using the CAPS-4 because this is data collected during phase 2. New data or new studies conducted by MAPS use the CAPS-5, which is a revised version of that measure. Now, one thing that I had not mentioned is that the DSM diagnosis for PTSD requires, quote, clinically significant distress or impairment in social, occupational, and other important areas of functioning. But I might argue that when looking at symptom severity or symptom reduction, studies in psychotherapy generally tend not to look at how people are growing or flourishing in social or occupational or other areas. So this is, to address this, we looked at something called post-traumatic growth. And this is defined as positive psychological change experienced as the result of the struggle with highly challenging life circumstances. How do we measure this? Well, we use something called the Post-Traumatic Growth Inventory, which is a 21-item validated measure developed by Tedeschi and Calhoun, 1996. And it consists of 5 subscales, which include growth in personal strength. I have a greater feeling of self-reliance. Growth in spiritual change. I have a better understanding of spiritual matters. Improvement in relating to others. I have more compassion for others. Appreciation for life. I can better appreciate each day. And a sense of new possibility. I established a new path of my life. And this is rated on our Likert scale from 0 to 5. And there's some interesting findings in the existing literature on this topic. Well, one is that generally PTSD symptom severity does not correlate or correlates weakly with post-traumatic growth. So in other words, the more severe your symptoms are, doesn't mean the more growth you have or that there's any relationship. And 2, there's a review study by Rupke in 2015, which looked at 12 randomized controlled trials looking to measure changes in post-traumatic growth after clinical intervention. Only 5 of those 12 found any significant changes, and generally those changes were varied from weak, although some were strong, but generally the findings are inconsistent. So the question that we are interested in here is, do participants in our studies report having improved relationships, appreciation for life, or enhanced sense of personal self-efficacy after MDMA-assisted psychotherapy? A secondary question I was interested in is this gain in post-traumatic growth independent of symptoms going down? So how did we do this? Well, first we looked at a sample of 60 participants pooled from 3 different phase 2 clinical trials of MDMA-assisted psychotherapy for PTSD, which used a triple-blind crossover design. All of the participants had to meet criteria according to the DSM-4 for PTSD, and a CAPS 4 score of above 50. It was also important that they had inadequate responses to previous pharmacological or psychotherapeutic treatments. In terms of who these individuals are, their average age was 40. There's an even split in terms of gender identification of either male or female. And we had a rather homogeneous racial sample of predominantly Caucasian individuals. It's important to note that this data is from phase 2, and since then, MAPS has really improved its efforts to include a more diverse population, so having a more representative sample. And these efforts have begun to show themselves. However, there's always a room for improvement. In terms of the kinds of traumas that these participants experienced, you can see that the majority of them experienced war-related trauma. This is because one of the studies that was pooled in to my data set was a study using veterans and first responders. But you can see that there is a pretty broad representation of different kinds of traumas at different periods of people's lives. Here you can see the groups. So 15 of the 60 individuals were in the placebo, or what we sometimes call the active control group, and they received between 0 to 45 milligrams of MDMA, while 45 participants were in the active MDMA dose group, receiving somewhere between 75 to 125 milligrams of MDMA. And all of the individuals, regardless of their group, received the psychotherapy. It's important to note that when individuals were responding to the post-traumatic growth inventory, they were anchored to their traumatic event. So they were responding to those items with regards to the traumatic event they identified at baseline. And so talking a little bit about baseline, the measures were administered once before treatment at baseline, at primary endpoint, which is 1 month after their second dose, at treatment exit, which is 1 to 2 months after their last MDMA dose, and 12 months a 12-month follow-up, which is 12 months after their last MDMA session. So how can we understand these results, or what are the results? Well, first we need to understand some of the baseline data. So first you can see that the average score on the CAPS was 90. The CAPS ranges from a minimum of 0 to a maximum of 136. This score represents a severe level of severity. On the PTGI, the post-traumatic growth inventory, the average was 37. The range on that measure is between 0 and 105. Looking at these averages by group, there are no baseline differences, which is what we would want to see in terms of their PTSD symptoms and their post-traumatic growth. And there is no significant correlation between post-traumatic growth and CAPS. So this is representative of, or consistent with the previous studies looking at post-traumatic growth and PTSD severity. Now, what are the outcomes? Well, first, looking at changes from baseline to their primary endpoint. So the reason why we have this time point is so that we can compare people who received MDMA and people who received placebo. And what we found, consistent with previous findings, we're looking at the very similar data set. People who received placebo had a 12.8 decrease in their PTSD symptoms, so they've gotten a little bit better. But people who received the MDMA had a decrease of 35.1. And so their improvement was significantly greater in the MDMA condition. And this is represented by an effect size of 0.88. What's new here is our look at the post-traumatic growth inventory. The placebo group had a decrease in their post-traumatic growth by negative 3.2. Whereas the MDMA group had an increase in their post-traumatic growth by 23. And the effect size here is 1.14. This is just another way to display the post-traumatic growth data visually, which might be a little bit easier. You can see that the MDMA group is the black line, whereas the control group is the blue line. At primary endpoint, here you can visually see that the MDMA group went up, the placebo group went down. At secondary endpoint, this is when the control group receives the MDMA, and when they're grouped together, there's an increase in post-traumatic growth. And 1 month after treatment, as well as 12 months after treatment, when the two groups are put together, these improvements in post-traumatic growth remain. So another way to look at this data, it's very similar, would be to look at correlations. And so what I wanted to do was see if there was a correlation between people's symptom reduction and their post-traumatic growth. And unlike previous studies, we found a moderate correlation in the MDMA group. This correlation, as expected, was not evident in the control group. The reason why I wanted to do this correlation was I also was interested in controlling for the changes in symptom or the symptom reduction. So the question would be, did MDMA-assisted psychotherapy contribute to post-traumatic growth regardless of symptom change? And the outcome here was there was not a significant finding. However, my guess is that with an increased sample size, we would find significance. However, that's just a guess. So let's kind of bring this to a conclusion here. How can we interpret this? Well, one, we found robust year-long changes in PTSD symptom reduction and post-traumatic growth. And so we can say that, yeah, this therapy does something beyond symptom reduction. People are reporting improvements in their social functioning and their meaning in their life, and their sense of spirituality. However, the extra step, we could not demonstrate that these post-traumatic growths would happen independent of the symptom change. Again, we're still talking about change beyond symptom decrease, but it seems like we couldn't identify an independent effect. So what are some of the limitations of the study? Well, one, it's self-report. So we don't have the behavioral or objective data to validate what people are reporting. And there's some critiques of the post-traumatic growth. concept. One idea is that maybe it's a positive illusion that's protective for people. And I also want to be really careful that we are not glorifying trauma and minimizing its harms. I think the post-traumatic growth concept is an important one, but by no means do we want to minimize the suffering that people experience as a consequence of trauma. So this is myself and my daughter, and we're looking into future directions. And one is that I would like to be able to increase the sample size here and see whether there could be an independent effect for MDMA therapy in terms of post-traumatic growth or other kinds of growth beyond just the symptom reduction. And this has important implications potentially for MDMA psychotherapy to enhance well-being and not just reduce symptoms. So I would like to thank all of my co-authors, as well as the study therapists and the clinical research team at MAPS, who are working very hard on the back end and often do not receive the credit that they're due. I thank you and look forward to the discussion.
Thank you so much, Ingmar. My mic is on, right? Yeah, my mic is on. Thank you, Ingmar. To shift our attention just away from symptom resolution and symptom chase to post-traumatic growth. And I think that there's also an acknowledgement of that in literature. And I think this has been published, or is it in a pipeline to be published, right?
It has been published in the Journal of Traumatic Stress, and it's open access, so anybody can access it.
Great, great. Now, a question that I would like to, we have just a few minutes. Question first to you, and then it's a cliffhanger also to Alan, of course, I think. From your clinical experience, where do you value the MDMA experience or the MDMA session in the post-traumatic growth perspective in balance with the reintegrative sessions? Is there, because what do you value? I know it's a kind of a sort of a dichotomy that I tried to present here. It's not really true, but how do you need to value the integrative sessions with respect to the post-traumatic growth and the meaning making?
Yeah, thank you for asking that question. Yeah, it is a very challenging one, and one that I would love to speak at length. I would say that of course, the integration sessions are essential. I think that I mean, I'm really a big fan of Alan's research. I don't want to steal his thunder, but I'm a big fan of his research on psychological flexibility, and I think, and meaning making, as you had mentioned, is a really essential part of the process. And I think that often happens in the integration parts. Not that it can't happen in the dosing sessions. And in fact, one of my participants reminded me in the dosing session. She said, integration is happening right now. So it really is a blurry line. But of course, I think the integration sessions are really important in just using that maybe the neuroplasticity, some of that psychological flexibility, and working with the meaning and symbolism that comes up as the consequence of the MDMA experience.
All right, thanks. And Alan, these growth appraisals or so, or the focus on growth, have you found that also in the study, or did you look at that in your study sample, or were people reporting that too?
So we didn't look at it directly in terms of the post-traumatic growth measure, but we did look at it in terms of what people reported in their long-term positive changes in their life, like changes in their well-being and their life satisfaction, overall changes in their relationships, that they were reporting that there were these long-term changes, kind of independently from just the changes in their mental health. And not a part of this study, but I'm also involved with psilocybin trials, and we haven't tested psilocybin yet for PTSD in a clinical trial setting, although I'm hoping to do that soon. But we have had lots of people in our depression study with lots of historical traumas that have occurred to them, and have seen similar things where finding resolution from that trauma is kind of a critical piece of their antidepressant effect of psilocybin. And whether that occurs during the psilocybin session or in the meaning making after, I think Ingmar's right. There's something really important about the psychological flexibility and people's ability to approach whatever difficult emotion they may be having about any type of thing, whether it's a traumatic experience or just the day-to-day life of surviving a pandemic.
Two questions, I think, before we close briefly or so. There was one question that Alan, you offline already answered to, but Ingmar, why do we favor MDMA in the treatment of PTSD? Any quick thoughts or so? Why don't we favor psilocybin or so? Or any thoughts on that?
Yeah, I've heard several explanations for this. I think that psilocybin is an interesting compound to study for PTSD. I think it has potential, and I think that we have kind of anecdotal evidence that it could be useful. But what convinces me is some of the pharmacological effects of MDMA that are unique to MDMA and not necessarily present in psilocybin, as far as I'm aware, in terms of effect of on the amygdala. Possibly hippocampus, just ways that, just as Alan was saying, that kind of difficult or challenging memories can be approached in a sense of safety, similar to the hormone effects, say on oxytocin or prolactin. So that might give it a slightly greater strength for that indication, but I think it's an empirical question, and we should evaluate it for sure.
Probably in the future, in an ideal world, we'll start with a session or two with MDMA to be followed with psilocybin. Don't you think that that might be a design that somebody would pick up?
Well, yes, certainly, and I'm aware that in underground settings that there's actually seems to be a preference for that approach.
Mm-hmm.
Again, not advocating for it. I don't engage in it, but it is something that I have observed. So maybe we often learn, right,
Sure.
from sort of the real world application.
Alan, any comments or so? And then maybe a final question from, actually, no, first let you comment. And we're going 2 minutes over time, but we may do 1.5 minutes or so. Alan? Any comments or so on this?
I don't have any.
All right.
Just that I think there's so much more work that needs to happen. I'll just say that there's so much more work that needs to happen, and I know that Ingmar and I are probably in agreement about that. That we'd love to see much more work on this topic. And
I'm agreeing with you. I'm one of the PIs from the European end, so we're on in the same boat here. So yes. Now one question: substance use disorders frequently co-occur. MDMA is not without risk. Considering this, how do we mitigate potential harm from using MDMA to treat PTSD? Maybe brief a comment, Ingmar. Do you want to?
Sorry, you had cut out for 1 second. Your question was mitigate harm.
How do
if an MDMA for PTSD? What harm is it that being mitigated?
Yeah, how do we mitigate potential harm from using MDMA to treat PTSD?
And this has to do with the sort of potentially neurotoxic effects of MDMA. Is that the kind of the question? I'm not sure what the.
Probably Thomas Ringwood has some thoughts about that. Yeah.
Well, I guess that's another area of study where I know people have proposed. Go ahead.
You can give a reference or so where you might give the author or the person who asked this question some reference where to find the answer.
Well, the one thing I would say is that we have looked at the possible neurofunctional harms that might happen as a result of MDMA treatment, and we haven't identified any, and that was using the R bands. And so you could look at some of the previous research, and we're not identifying some. There are, I think, important implications around the therapist and the therapist's roles and making sure that therapists are well trained and treat the person who has a trauma history appropriately. I mean, so it's a question that we don't have the time for, but I think there are many aspects of that question that
we could do a back channel or so if there's a room where this person could go, but also back channel. And I would suggest to the person, Rick Doblin is often asked this question, and there's a panel where Rick Doblin is, and he can give also some insight about his experience in that, and direct the Thomas to that. Alan, some last thoughts or so, or just some observations before we wrap up?
Well, there's a question in the chat or in the Q&A about what it's like, or what my thoughts are about being a person who's white, but studying the topic of racial trauma. And I'll just say that there's a lot of different types of diversity that aren't always visible. And for me, I felt very connected with partners in academic science and students in academic science who are people of color. And I felt like the best use of my power and privilege was to try to use that power and privilege to help elevate voices of others when I can. And part of that was elevating the study and working with others to bring this to light. So I don't want to diminish their contribution. I just happen to be the person presenting at this talk, but Monica Williams will be presenting this in other ways, and hopefully other people from our team.
Yeah, and I know that MAPS is also recruiting therapists for their training programs of people of color. And I know that in the one that we're doing soon in Europe, in the Netherlands, we will also be advertising and seeing if we can include people of color in our training as well. Thanks, Alan, and thanks, Ingmar, for your contributions and shifting beyond symptom resolution and interracial trauma. I want to close this session. Thanks for your contribution, and then I'll give it back to the green room. And have a great day.
Thank you.
All right, thank you, Eric, and thank you both, Alan and Ingmar, for the great presentations. I just want to have a minor announcement. We have a little workout session going on right now, but as we are a little bit over time, you have 5 more minutes to join if you want a little bit of guided movement. And also the link to the after talk for this panel or this track is visible in the chat, and you can find it in WUFA. So if you want to continue the discussion, please go there. And after the little break of a few minutes, we have 2 tracks coming up. One is psychedelic treatment for alcoholism, and the other one is a Chacruna panel about diversity, equity, and access in psychedelic medicine. So you can choose whichever track you want to join, and see you all soon. Thank you very much again.